And thanks everyone for attending. I think we are quite a nice small group today. So hopefully this will be as informal as possible. And if you have any questions throughout the talk, just feel free to shout them. I don't think I can see any hands up. But as I said, we're a reasonably small group, so hopefully we can make this as interactive as possible. Mel has already given you a very nice overview of our program of work. So I'm not really going to repeat that much. What I maybe want to say is that NIHR has actually funded other priority areas as well. So there are about 9 other priority areas that are funded at the moment. And as Mel have said, we are leading the collaboration on adult social care and social work. And you might wonder what's actually different about the program of work that we are doing and what actually set us apart from everything else that is happening. So I suppose what's quite key about our work is that we are looking at the implementation of evidence-based evaluation. So we are not looking at any sort of evidence. We are looking at evidence that can be implemented at scale and is sustainable as well. And it's evidence that's actually needed by both the service users who are using the health and social care services, but also is very relevant for the current configuration of social care services and the practitioners that are working within this configuration. So it's really about applied research in social care, which is quite novel as well, with an implementation angle to it and making sure that any type of work that we are doing in this area is relevant and it has an impact on practice. So we have been funded indeed since 2021. So we are now, we can say that we have 5 years funding from NIHR, which is quite great for this area of work. And we have quite a nice geographical spread across the other the applied research collaborations. We have collaborators from the Oxford and Thames Valley area and going up to Northwest Coast and Liverpool and Newcastle. So hopefully any type of work that we are carrying out in this field, we can say that its impact is relevant at national level as well. We started off back in 2021 through a very basic prioritization exercise because NIHR has said this is the area that we want you to do work in, but social care and social work is such a vast area. So we went through a very basic but very thorough prioritization exercise, trying to understand what are the topics that we need to work on to begin with for the next 3 years and now for the over 5 years period. And after we identified the topics that we were interested in, that were a priority for the service user, for researchers and professionals, in the next 3 years of the work, we started really developing those projects and actually offering the implementation support for those projects to properly kick off. The second part of the project now has moved into the extension period of the next 18 months now, where we are really trying to see if things that we have developed in the first phase can be implemented and evaluated within the extension period. And nevertheless, within the kind of something that brings everything together is this improvement of the evidence-based in adult social care and social work and building the research infrastructure and capacity and capability building in this area, which I think is one of the key challenges that we are all facing at the moment. So we have quite a big remit, and you can say there are quite a lot of so we have 9 applied collaborations in total, but we actually have 11 universities involved. So as you can imagine, this is quite a complex and rather complicated program of work. We are currently involved in conducting 6 different research projects. And I know I have an hour that I can literally speak for an hour for each of them. But I think what I'm going to try to do, I'm just going to try and maybe summarize the main issues with each of those 6 projects and maybe have some time at the end to take some questions and engage in some discussions. I have also added at the end a list of publications. So we have about 20 odd publications that we emerged from this work, either in press or about to be published or already published. So if there is any sort of extra information that you need, you can also get in touch or consult the references. But hopefully what I can achieve to do in the next 20 minutes or so is give you a flavor of the type of work that we are currently conducting and maybe engage in some interesting discussions about so what at the end of this, because there will be an end of it at the end of December 2025. So the 6 projects that we are currently conducting, they are different but similar in some regard. And you might notice that some of the methodology I'm going to present looks quite similar across the whole 6, which is quite an interesting finding because none of those projects actually consulted with each other in terms of, what are the actual methods they're going to use. So it's something that sort of naturally evolved, which is quite an interesting finding in itself and something that we might want to elaborate on when we try to pull together the lessons from all the projects that we are currently involved in. So the first project that we are doing is one that we lead here in Arkansas and Sussex, and the lead is Nick Smith from the CHSS, and is looking at the idea of well-being in care homes and the implementation of care planning. We all know what care planning is, and it's been the focus of research especially in care homes for a long time. But what the literature is saying that care planning sometimes is not always based on the outcomes that the service user or the resident actually wants. So if we look at the literature, most of the literature around care planning is looking at the health-related quality of life and not very much about more the social aspects or the social care-related quality of life aspects of care planning. Especially at University of Kent, there's been a lot of work done in ASCON measures, which is the adult social care related quality of life, and a big push to understand care planning from a more person-centered approach and point of view. There are other similar measures that have been developed in the same perspective. For instance, the ISCA measure, the capability measures for all the people, developed at Bristol as well. So they are all trying to bring this kind of centeredness and the whole person approach to care planning that's actually needed in this area. So what we did in this project, we embarked in understanding what actually care planning means for the sector and what are the perspectives of both residents, their carers, their families, and also the practitioners who are working in the health care homes. We engaged in a number of activities that have produced some papers as well, which are noted at the end of this presentation. So we did a scoping review of the care planning intervention in care homes. We identified over 5,000 papers that were relevant, and we tried to summarize the key lessons in relation to what makes a successful care planning intervention in this area. We also consulted with the sector. We had interviews with relevant stakeholders in care homes, including managers and front care providers, about what are the actual barriers and facilitators to our care planning. And something that's quite novel that we are trying to do, and we are still kind of trying to untangle the paper around it, is actually how do we define person-centered care planning? What does it actually mean? And when we talk about its implementation in practice, how we make sure that those barriers and facilitators are identified and used in case a similar approach is implemented into a new care home. So we are at the stage of actually untangling this more kind of theoretical understanding of person-centeredness within care planning itself. After we developed all this work, all this, if you like, empirical work, we also have some really ambitious plans that have actually started and they have progressed quite considerably. So we are in the process of conducting a Delphi study with stakeholders that are working in care homes about a best practice guideline around person-centered care planning. And we are currently in round 2 of the Delphi. So we developed a questionnaire with about 75 statements based on the data that we have previously collected. And we had about 100 responses in first one, which is great for a Delphi study. And we've just sent around the second round of the Delphi, hoping that we can produce this documentation that will have both a lay version and also more like in-depth version for the care homes to consult when a resident is admitted in a care home. The other arm of this study within the extension period, I've already mentioned the ASCON measures and the ISCA measures that the team at Ken has a lot of experience in actually evaluating them. So we are trying to do a little bit more work based in the UK. There is quite a lot of work in Australia that the team have done. So we are trying to work with a small number of care homes, so some in the KSS area and some in the London and Oxford area, trying to pilot the ISCAP and the ASCON measures and do some sort of evaluation in order to understand what's about the social care related quality of life measures and what is their usefulness within care homes. The idea is to bring all this information together within the best practice guidance, and at the end of the study, just give something back to the sector in terms of making sure they know exactly how to implement care planning and what are the key things that they have to take into account. We're moving from care planning to digital technologies that support social well-being for community dwelling older adults in receipt of social care and their carers. This is quite a mouthful of a title, but we call this project DITSO. So in very simple words, we are interested in digital technologies to enhance social well-being. And you might think, okay, but this has actually been done quite a lot. It's quite interesting because after the COVID pandemic, when the national priority actually started to function in 2021, there was indeed a boom in research around digital technologies. But even back then, most of the focus was on health-related technologies. So we've seen lots of work in replacing face-to-face consultation, work around telecare, falls prevention, and so on. So there was quite a lot of work in that area. But what we were really interested in, what's our kind of unique selling point in this field, is like we were interested in those digital technologies that are actually supporting social well-being. So not necessarily those ones that have a healthcare element related to them, mainly in relation to those small kind of niche local authority commissioned technologies that can have an impact on the day-to-day life of people living at home. And we kind of like, we did a brief scoping of the literature. And again, most of the work, even within the social care area, was within care homes. So we identified this as being quite a niche in terms of how the digital technologies can be effectively implemented to prevent social isolation and prevent loneliness for people living at home rather than those ones in care homes, where there is a big focus even up to now with artificial intelligence and robotics and so on. So this was our kind of like unique selling point at that point when we started this work. So again, we try to look at the literature to try to scope this kind of more like small social care related technologies, and we couldn't actually find that much in terms of what has been published. Most of the technologies that are in the literature are things that like mass market technologies. For instance, the use of Alexa, for instance, and people just trying to give it different uses in terms of, making people feel more connected with their families or reminding people about their medication. So we couldn't really find much in terms of the other type of technologies that are maybe commissioned by the local authorities to make a difference at scale rather than for specific individuals. So after we did this scoping review, we actually went in and we ran a series of interviews, which were really enlightening, especially with with the commissioners and the tech providers. And every type of interview seemed like a sell pitch from them to us, which was quite interesting to untangle. We also spoke with the older adults about the value of digital technology and an adoption, and how they actually perceive the digital technologies to help their social well-being more broadly. After we collected all this data, we put all the data together and we run two work cafe events, and we are trying to co-produce this best practice recommendation about how do we actually adopt digital technologies that work for this type of service user, and how we can make sure that these digital technologies are actually improving the social well-being outcomes. And again, this was something that we identified as a gap in the field. We are in the process of actually finalizing this guidance recommendation, or a best practice toolkit, if you like. And from the data that we have extracted in the first phase, we now want to focus on two key service providers. So one, service users. So we noticed that the service user with dementia are the one that can benefit more from this type of technologies, and service users or residents who are suffering from vision loss. So these are the two main areas that we're going to focus now. And we are in the process of identifying two digital tech providers that are willing to work with us and actually test some of the technologies with these two categories of service users, and make sure that whatever we develop at the end of it is really relevant for the hard to reach voices, if you like, because these two categories have been really neglected in the literature. So it's quite exciting moving forward. What I would probably say, we need to be very careful in just not transforming this in some sort of full scale evaluation of the digital technologies, because that's not something that we want to do at the moment. It's mainly just test the waters and just understand how similar technologies can be used for this category of service users, and what are the lessons that we can learn from it. We don't actually have the resources to make fake hopes for the digital providers, thinking that we're going to evaluate like full scale technologies. Um, but there are possibilities of actually developing further grants to work with them. So one example, just very briefly, or we might end up working, for instance, with Cradle, who is like it's a TV-based digital technology that's setting up reminders for the users and so on. So it will be quite interesting to see how these collaborations are planning out, and if there is any scope for doing a full evaluation, maybe in Dark too, for instance. Um, Vista. So Vista is another lovely acronym, and again, the topic is quite different, but in the same time very relevant for adult social care and social work, because it relates to intimate partner violence and abuse. And there is a lot of literature looking at domestic violence. Especially the local authorities more recently are trying to move away from this failure to protect discourse, where all the focus is actually on the adult as being the victim. So what we were trying to understand is this process with this project is how we can actually adopt a more kind of family-centered approach to domestic violence, and safeguard both the adult victim and the child survivor as well. However, there are a lot of issues when working across adult and children services. Some of the channels of communications are not very clear, and also in relation to the multidisciplinary working within the domestic violence field as itself, thinking about the importance of involving the police, the justice system, and so on. So there are a lot of things to untangle when it comes to IPVA, and also like how we make sure that whatever work we are doing, it responds to the needs of both the adult and children impacted by IPVA more broadly. So we done quite a lot of work in this area with the focus, as I said, on the family approaches to domestic violence. So we are just about, I think, we're going to the fifth round of reviews with this paper, which is a systematic review looking at experience and attitudes of stakeholders around what are the best ways to respond to the needs of survivors of FPVA. So we've done a very, very thorough systematic review, and then we engage into a practice mapping. We run a survey nationally trying to identify innovative practice models that are crossing the boundaries between adult and children services, and also have this multidisciplinary focus to them. And we conducted interviews across 4 sites, mainly based around the northeastern North Cumbria area. And we did a proper process evaluation about how these innovative models of responding to the needs of survivors of IPVA are implemented within the normalization process theory and some other implementation science approaches that are kind of trying to unpick the key drivers for these models and the generalizable lessons that can be adopted for other areas as well. Within the extension phase that has just started, we are running a series of workshops with the women survivors of IPVA just to finalize and really try to understand how these practice recommendations can be implemented. And what we want to do now is, after we actually finalize the toolkit, we want to work with the local authorities to actually implement it and see what are the lessons that can be learned, and also kind of like to identify the key contextual issues that we want to take into account. And I think this is quite an important area of work, especially given the fact that domestic violence is a topic of national interest, and some of these toolkits can be adopted nationally out with the northeast of North Cumbria area. So I think it's quite exciting in terms of what we're gonna produce at the end with this work, and again the relevance for both children and social care services. So again, there might be opportunities for the new work, for instance, to take on some of this new work and try to understand how services work together when addressing similar issues. Um, Not surprisingly, again, we have two projects that are looking at strengths-based approaches for adult social care and social work. Um, and strengths-based practices, especially within the applied healthcare research, is something that has been studied quite a lot and something that is promoted quite heavily at the moment. Again, within the social care area, some of the evaluation, some of the evidence base for these approaches is still relatively undeveloped, or some of these approaches are mainly evaluated internally. So we saw there is scope to actually do a little bit more or work to understand, how can we use this evidence more effectively. There are several strengths-based approaches that are used within social care as well. Some of them actually borrowed from healthcare and kind of adapted for a different area. So we focused on two main strength-based approaches. So the first one, we called it person-centered community-based support services, which is very long. Um, but it's actually what used to be called the connected community model that was initially adopted within healthcare and then developed within healthcare and then adapted with the generalizable lessons for social care as well. So this connected community model was primarily developed within the Liverpool area, which is an arc northwest coast. So they had a really massive interest in actually developing this way of working. Um, at the moment, this kind of approach is embedded within the GP practices, but also voluntary services are adopting it more and more as well. And you probably might wonder what is this connected community. So it's very much the old social prescribing model that was based on the link worker that was identified in the GP practices that used to pretty much match service users with the needs that they had. And the idea was to identify those needs within the community. It was all about prevention rather than intervention before the service user actually reaches the point of crisis and might need to access more specialized services. So disconnected communities were originally developed to prevent loneliness for people suffering for all sorts of mental health difficulties, but the model has been adopted more and more in other areas as well. So given the fact that there was this interest in the Northwest Coast area, again, and the evidence base for social prescribing, again, sometimes is not very developed. We thought there is some scope to do a little bit more investigation around what is it about connected communities that made this model so successful in that area. So and again, at that time we had a COVID-19 pandemic, so we were interested to understand, what sort of adaptations have been made as a result of the pandemic as well. So this was quite a thorough evaluation of the service, which again was based on a combination of implementation science frameworks, including the consolidating framework for implementation research and the normalization process theory as well. We did a review of all these case studies. So we identified 4 case studies in the area that have used the model. And also we done interviews, quite a lot of interviews with service providers as users to inform the further implementation of the services and try to understand the barriers and facilitators. So in total, I think we conducted about 70 odd interviews. So this was quite an in-depth evaluation. And we also identified over 200 documents that were relevant to explore for the documentary analysis of the case studies per se. So based on the data that we have collected, again, the plans where we have almost finalized the toolkit that consider how this kind of social prescribing services are implemented, and most importantly, given the fact that they're embedded within a more kind of healthcare setting, what are the lessons that we can adopt for social care? In the extension phase, we are now in discussion to pilot this toolkit with other organizations in similar sites, some of them within the Camden Surrey and Sussex area, and hopefully just come up with some lessons that can be applied nationally as well, because there is an appetite for using services that are not using specialized secondary NHS services that are more like community-based rather than specialized, who are requiring more resources and funding and so on. So I think there is a real scope to develop something that will be useful for the services and the service users as well. The sibling of connected communities is called community-led support. So this is the second approach that we were interested in evaluating, and this is led by ARC West Midlands and ARC South London. And I did mention that connected communities was started off as being quite a small kind of service developed within the Northwest Coast area. Community-led support claims to be a system-wide change. So at the moment, the approach has been implemented in about 30 local authorities in Scotland and England as well. And it was implemented by an organization called the National Division Team for Inclusion. So they are claiming that the community-led support approach is, rather than being small scale, is something that is already large scale. And they have some evidence that the approach actually works. And there is scope for all local authorities in England and Scotland to actually take on this new model of working. Similar with the community connected communities, the community-led support is based on the same approach of actually looking at the individual capabilities and things that people are really good at, and making sure that the services are used before the person reaches the point of crisis. So they want to identify everything that's available within the community that they can use before actually more specialized services are being used. A very nice example that we want to, for instance, investigate a little bit further in the extension period is this idea of community benches. So literally, people who have the knowledge, the expertise, they set up a pop-up store, let's say in the supermarket, and people can actually come, ask for advice, get referred to the service, and really create this kind of community feeling, community-based feeling around, any sort of issue that the service user has can be addressed, or at least can be advised around what will be the best ways of going about it. So it's quite an interesting approach. And again, it's all about, based on the idea, how can we prevent things escalating? What can we do that is closer to home? And it's almost like, bringing back, like old values around, like making the community more friendly, making community closer to home, accessing things much quicker, and so on. However, although this kind of approach and ethos of working in a community-led support, you could say that this is something that obviously it's embedded and everyone is working in this way. Sometimes it's not very apparent. So there are a lot of other things-based approaches that are used in local authorities, but we don't actually know what is it about them that makes them successful. So how are the people working together? How do they actually come together as a group? How is the group dynamic working, and so on? So we really try to untangle and see if there's something special about this community-led support, or is it just another approach of strength-based practice within the system. So what we, and not surprisingly, although the National Division Team for Inclusion is a massive organization, if when we looked at their website, all the evaluations were quite internal, so they've not really had any external evaluation of their work, and they were very eager to partner with us to do this evaluation, and we thought that this is an amazing opportunity to do it. So we're working alongside with the NDTI. We actually completed the first phase of the evaluation. We looked at all the documentations for the 30 local authorities that are involved in the program. Um, we selected initially 5 case studies that worked with us across England, and we did really a theory of change interviews exploring things like leadership, culture change, co-production, and use of data. So these were the 4 pillars that we were really interested in exploring. Uh, After that phase of analysis, we went into more detail. We did some sort of participant observation within 3 sites. We went in and observed how the community benches are working. We spoke with the staff. We spoke with the people on the ground. We spoke with the service user, trying to understand what are their perception of how effective community-led support is. Very much importantly at this stage, compared to all the other methods that we've used, we've tried to do a bit of statistical analysis as well to offer the hard facts. Okay, so how is this CLS, the sites that are adopting CLS are comparing to the non-CLS sites? So we look at differences in process and service outcomes, and there were significant difference in terms of savings and improving service user outcomes for sites that actually adopted CLS as a way of working. Within the extension period, we plan to go back to some of these sites to see what progress have been made in relation to the leadership culture and co-production site. And we really want to go beyond the 5 case studies that we have included in the evaluation. We want to see if maybe other sites are also interested to partner with us and try to understand, what it takes for a new site to become a CLS specific site as well. And as I mentioned before, something we are really interested in is this idea of community hubs, benches, lounges, and how this idea can be adopted in other areas as well. So I think there is quite a nice potential to do some more work to untangle that. So these were the 5 main projects that it's a lot. I'm aware that it's quite a lot to take on. These are the main 5 projects that we have been involved in. And last but not least, and of equally important, is our PCIP group, Public Community Involvement, Engagement, and Participation. So this is at the forefront of everything we do in the National Priority Program, and something that started off as being more in an advisory role. It developed in being a project in itself, giving its importance. We've done a lot of work in PCIP, and I think I presented some of that last year at the Research Week. So very briefly, we have a national strategic advisory group of 50 people who are advising across all the projects I have just presented. There are people from across England. We also, each of those 5 projects I've presented, they have their own individual advisory group who is feeding into the main one and advising on specific issues that appear within their individual projects. And we're also doing a realist evaluation of public participation across the national priority. This is led by ARC West Midlands. It's a massive program of work trying to understand, how did we do it, and did we do it any differently? And if we did, was it effective? And did people see any benefit from running public community engagement in this manner? We conducted interviews with researchers, including myself, who are working across the projects. We also spoke with all the public contributors that are involved in the national priority, and also with the leads who are leading and more kind of advising the projects in a more kind of mentorship capacity. We have also developed, and that's something that it raised quite a bit of interest at the previous presentation, or a template to actually log the impact of public contribution across the national priority program. It's a template that we complete after each activity, trying to understand, how did the public contributors, how did they contribute to the project, and if they think this was effective, and what are the things we might need to change. And I think this is a brilliant activity that we do, and it's something that we can use to evidence the effect of public contribution and participation for our work. Within the extension plans, we are tidying up these recommendations about doing public and community engagement within adult social care and social work. And I think what's quite important, we want to link this with all the other activities that are happening. There are quite a lot of activities that are happening simultaneously in this area, led by other big centers, led by small organizations, by the School of Social Care Research, and so on. So we are trying to sort of link all these initiatives and do some consensus building to create some sort of unified version of how to do PCIP in this area. And once we manage to tackle that, we want to share the findings in some sort of report or webinar that will be freely accessible for everyone. And again, what we want to do is, in the extension period, we hope to keep together this amazing group of people, of 15 people that are advising on a national priority. And we already had a face-to-face meeting in July in Birmingham. So hopefully we want to keep this group together and maybe involve the group in the next phase as well, if there is any opportunities for further funding and so on, including inviting them to the consortium meetings and so on. So they are quite ambitious plans, but in terms of PCIP, I think the most important outcome will be developing this kind of unified guidance around, how to do public community engagement and participation effectively within adult social care and social work. So I suppose this is like a very, very, very quick tour of the work that we are doing. And what I was doing this presentation, This question keeps popping into my head in terms of so what, and what are the implications for capacity and capability building in this area? Um, and we know there is a lot of work in applied healthcare research in relation to know how you make sure that you kind of polish the infrastructures and improve the skills of the sector in doing this type of research. And it's been, especially within the RKSS, it's been quite a lot of work trying to understand what is our strategic approach in doing that and where do each strand of the work actually sit. So this is a graph that Mel has kindly put together, and I'm stealing it for the purpose of the presentation, because I think this is something that we are all kind of trying to work towards, trying to understand how this might work for our way of work and where each project actually is situated. And there is a lot of activity within RKSS in terms of capacity building, and you've might heard about it today and during this research week as well. We have the regional social care capacity building that is now leading some of the work in this area. There are some fellowships that have been awarded. There are development springboards awards that are offered to people in order to increase their skills. Then if you look in the triangle again, we are the National Social Care Team Lead. So again, we are looking to understand the second sector challenges for research. We try to understand all the other research activity that's happening across the arcs. We want to understand what sort of activities other individual organizations are carrying out. And then we have the National Priority Program, which I've just described, which again is doing research and implementation in around area, is trying to understand the capacity needs and challenges and trying to understand, the willingness of the sector for implementation. Within the National Priority Program, we are a vast range of researchers, public contributors, sector providers, tech providers. It's a wide range of people involved in the program. Some of them have an appetite for getting involved in research in this area. Some of them want to develop their skills. They want to progress their career and so on. So in the end of the day, what we want to create is this national picture and the synergized approach within capacity and capability building. So I do believe that us as a national priority for adult social care and social work, we do have a nice place in this picture in terms of, what we can offer. But there are a lot of crossovers and similarities. Um, so these were the things that I have reflected on while I was doing the presentation in terms of maybe just very briefly for the next 10 minutes or so engage in this kind of discussions about capacity and capability building. I come from an applied healthcare research background. Um, so again, I'm still battling with these issues in terms of adult social care and social work. So capacity and capability building needs to be developed for a purpose. So it needs to be meaningful, it needs to be developed consistently, and it needs to be sustainable in time. So you can't just develop something that's going to work now. So how can we make sure that these activities pass the test of time, for instance? Again, as I presented before, there are so many contributions made from different organizations in social care, even more so than in healthcare. We have a lot of, there is a potential risk of duplicating a fragmentation in the same time. So I suppose I was wondering, can the barriers, we have different mandates, skill sets, time scales, pressures of these different organizations, can we address them through working more strategically and collectively? So how can we make sure that we join forces in terms of running these activities and making sure that capacity and capability building is at the forefront at everything that we do? And of course, I know that's something that sometimes we don't have enough resources to do, or we've not given the remit to do it. But I think the focus more and more is about measurable outcomes and impact. So how should we go about measuring the effectiveness of these capacity building activities? And I think that links back to if they work, there will be more funding for them, and then the research infrastructure will kind of, self-develop in time, I suppose. So I'm just gonna probably just stop sharing for a second and just see if there are any thoughts or comments really.